A nurse parks on a quiet suburban street, carries a medical bag to the front door, and enters what looks like one of healthcare's simplest businesses. There is no operating room, hospital tower, crowded waiting room, or expensive equipment suite. The patient already has a home, and the clinician brings the care. Demand appears obvious. Older adults want to remain home, hospitals want safer discharges, and families need help managing serious conditions after a medical event. That picture is real, but incomplete. The house is only where care happens. It is not the complete business the owner must operate. Before the nurse arrives, someone receives a referral, verifies the payer, confirms the service area, gathers clinical documentation, checks eligibility, and tests staffing capacity. A clinical manager oversees the plan, a scheduler builds the route, and the clinician must travel, assess, treat, communicate changes, and complete the record. Then coding, quality, billing, and collections teams must convert that clinical work into a defensible claim and eventually actual cash in the bank. The owner is not simply sending caregivers into houses. The owner is coordinating a regulated clinical labor network across time, geography, documentation, and payer rules. Care at home also hides an important economic boundary. Enormous community need does not automatically become Medicare reimbursable skilled home health demand for an agency. Many people need bathing assistance, meals, transportation, companionship, or continuous supervision. Those needs matter, but they do not automatically qualify as Medicare skilled home health. Medicare generally requires qualifying skilled services, part-time or intermittent care, homebound status, practitioner involvement, and a plan of care from a certified agency. It does not become a 24-hour custodial program simply because a patient is older, vulnerable, or requires extensive help throughout the day. So the first ownership illusion is demand. Community need can be enormous, while the portion that becomes eligible, staffed, documented, and collectible remains much narrower. The second illusion is capacity. A vacant apartment can wait for a tenant, but a nurse's unused Tuesday afternoon disappears when Tuesday ends. That is why the real asset is the complete network connecting referrals, intake, clinicians, patient homes, documentation, payers, quality systems, and cash collection before capacity disappears. Suppose a home health agency is offered for sale. The brochure highlights census, revenue, referral relationships, and a Medicare provider number as valuable assets. Those items matter, but they do not answer the central ownership question. Which parts of this operating system actually transfer when control changes hands? The legal entity may transfer, while state licenses may renew, require approval, or follow different rules depending on the jurisdiction and transaction structure. Medicare enrollment may continue, or federal ownership rules may interrupt the assumed path. Medicaid and commercial payer contracts can require separate notices, consents, or recredentialing. Receivables may be included, excluded, or adjusted. Accrued payroll, denied claims, refunds, recoupments, and pending audits may remain attached to the agency after closing. Then come the operating assets that rarely appear clearly on a balance sheet: experienced managers, intake judgment, scheduling knowledge, coding discipline, and quality control. A strong administrator understands local referrals. A clinical director knows the patients, workforce, survey history, care standards, and problems hidden inside daily operations. Scores know which clinician can reach each neighborhood before traffic turns a workable route into an impossible day of delays, gaps, and overtime. Coders, billers, and quality staff understand how documentation moves through the system and where a weak record could delay payment or trigger repayment exposure. Those employees create enterprise value, but the buyer does not own their future labor. Their departure can remove capability faster than software can replace it. Referral relationships work the same way. Hospitals reward quick responses, reliable starts, clear communication, and strong outcomes. But those referrals remain relationships, not property. If key staff leave, response time slows, or quality falls, referral volume can move elsewhere even though the buyer still owns the legal entity. Technology forms the agency's nervous system. Electronic records, scheduling, payroll, billing, telephony, quality reporting, cybersecurity, and mobile documentation must work together reliably. The complete ownership unit therefore includes licenses, payer relationships, workforce, territory, governance, technology, receivables, liabilities, records, and the working capital needed to operate. The buyer is stepping into a moving clinical system, not purchasing a static asset. If coordination breaks, the legal shell may remain while economics disappear. There are three broad routes into this business: build a new agency, acquire an existing provider, or enter through a platform or franchise structure. Each route solves one ownership problem while creating another, because speed, control, inherited history, and operating support carry different forms of risk. A de novo agency starts with a clean history, without inherited denied claims, old survey deficiencies, questionable referral arrangements, or resistant legacy systems. The owner can select technology, define the service territory, establish documentation standards, recruit deliberately, and build the culture around a chosen operating model. But a clean history also means no census, collections, labor network, referral trust, or proven operating record when fixed costs begin immediately. Licensing, policies, enrollment, survey preparation, accreditation, payer contracting, recruiting, and referral development must advance before stable revenue can reliably support the organization. During that build-out, payroll, software, insurance, legal, compliance, and management costs continue every month, even when patient volume remains small or non-existent. An acquisition appears faster because patients, staff, contracts, records, and collections already exist. But immediate operations can still conceal inherited weaknesses and dependencies. The buyer may inherit weak receivables, departing clinicians, scattered territory, fragile referral relationships, or documentation that supports historical revenue poorly after closing. A strong census on closing day is not the same as durable census after leadership changes, retention bonuses expire, and referral behavior adjusts. Federal enrollment rules add another layer. Certain majority ownership changes within the applicable window can prevent billing privileges from simply conveying to the buyer. Unless an exception applies, the buyer may need a new enrollment and certification pathway, changing transaction timing, liquidity needs, and expected value. A careful buyer verifies enrollment dates, ownership history, branches, service areas, surveys, sanctions, cost reports, payer notices, and provider agreement status before closing. A franchise or management platform may supply recruiting tools, policies, software, marketing, and support, but responsibility for care and compliance remains with the provider. Certification grants permission to participate, not proof of excellence. The business is everything required to make the license useful, defensible, and economically productive. Home health looks asset light because the agency does not build a hospital in every market. But low physical infrastructure does not mean low total capital. A de novo operator must fund legal formation, licensing, policies, survey preparation, software, insurance, recruiting, credentialing, training, communications, cybersecurity, and basic office infrastructure. More importantly, the agency needs enough runway to pay clinicians and operating costs while claims move through documentation, submission, payer review, and collection. An illustrative startup range can move from several $100,000 into the low millions before stable scale. But it is not a universal market quote. State rules, local wages, payer mix, clinical disciplines, growth speed, certification, and contracting timelines can materially change the capital required before operations stabilize. An acquisition carries a different capital stack. The purchase price is only the opening line, not the complete amount required to own and operate. Add diligence, legal work, working capital, staff retention, recruiting reserves, technology integration, insurance changes, claims reserves, and post-closing growth capital to the price. If debt finances the purchase, add fees, interest, principal, covenants, and liquidity requirements that continue even when census, collections, or staffing performance weakens. If the seller removes working capital at closing, the buyer can purchase the company and immediately need more cash simply to fund payroll and operations. A common mistake is valuing the agency on historical EBITDA, financing the transaction, and assuming that reported EBITDA will become distributable owner cash. Historical EBITDA may include a full-time owner without a market salary and exclude recruiting, technology replacement, compliance investment, claims reserves, and working capital growth. It may also reflect a favorable payer mix or staffing pattern that changes after closing, while principal payments remain outside the reported operating measure. Growth can worsen the cash problem before improving it because a new patient creates clinician payroll, mileage, supervision, scheduling, documentation, and supply costs immediately. A claim is prepared later and paid later still, so rapid census growth can expand payroll faster than collections, while accounting revenue continues rising. A resilient owner funds delays, denials, turnover, and slower growth, financing the full bridge from licensing to labor, claims, collection, and eventual owner cash. When care moves from a facility into a private home, regulation does not disappear. It follows the patient and clinician through the front door. A Medicare-certified agency operates under federal participation requirements covering patient rights, assessment, care planning, skilled services, quality improvement, emergency preparedness, records, and organization. State rules add another layer through agency licensing, administrator qualifications, clinical supervision, background checks, branch approvals, aid training, Medicaid enrollment, and possible market entry restrictions. Those state requirements are not identical nationwide. A plan that works in one market may face different licensing paths, reimbursement structures, or entry barriers elsewhere. The coverage boundary matters just as much because community need and Medicare-covered skilled home health are related, but they are not economically interchangeable. Medicare generally covers qualifying part-time or intermittent skilled care for eligible homebound patients when practitioner involvement and an appropriate plan of care are present. Continuous supervision, meals, unrelated housekeeping, companionship, and custodial personal care alone do not become covered skilled home health simply because someone is vulnerable. That distinction shapes intake, where the agency must translate a broad request for help into a specific clinical, coverage, staffing, and documentation decision. When a referral arrives, intake first asks whether the patient meets coverage rules and whether the required practitioner orders and clinical records are complete. The team must also determine whether the agency serves the location, the payer is active, and the ordered care can be delivered safely. Finally, intake checks whether the right nurse, therapist, or aide is available at the required time and within a workable service route. Accepting every referral may look like growth, but it can create missed visits, unsafe assignments, delayed starts, poor documentation, denied claims, and damaged trust. Regulation therefore becomes an operating filter, determining which patients are accepted, which services are delivered, how care is documented, and how performance is proven. Survey, accreditation, quality reporting, and compliance are not decorative badges. They test the operating system and can influence payment, reporting, and referral credibility. The owner must turn policies into schedules, assessments, supervision, records, and reliable field behavior, because only operational compliance creates a collectible revenue pathway. The economic life of a home health episode begins before any clinician reaches the patient, because every referral must first enter an operating system. A referral may arrive from a hospital discharge planner, physician office, clinic, health plan, skilled nursing facility, or another community source across the market. The clock starts immediately because referral sources value quick responses, clear communication, dependable acceptance decisions, and the ability to begin care safely each time. Delay creates leakage to another provider, yet speed without discipline can produce an accepted patient the agency cannot staff, document, or serve safely today. Intake verifies the location, payer, coverage, diagnosis, practitioner orders, clinical records, requested services, patient needs, insurance status, and the expected start date for every case. The team then checks whether the agency serves that territory and whether qualified nurses, therapists, or aides are available within the required window safely. A difficult referral may strengthen an important relationship, but it can become an operating loss when staffing, documentation, geography, or clinical complexity exceeds capacity. Once accepted, the agency coordinates practitioner requirements, builds the plan of care, confirms staffing, and prepares the start of care assessment before field services begin safely. OASIS documentation captures clinical information used for care planning, quality reporting, and payment classification, so early errors can travel through the entire episode downstream. Then scheduling begins, converting an approved clinical plan into specific people, time windows, travel routes, visit priorities, and supervisory responsibilities for every accepted patient. A nurse may be available in the wrong county, while a therapist has capacity on a day that does not match the ordered care. Even a workable schedule can change during the day when a discharge moves, a patient cancels, traffic increases, or another patient's condition suddenly requires attention. The scheduler is not filling calendar boxes. The scheduler is allocating scarce licensed capacity across geography, clinical urgency, payer rules, and patient availability simultaneously. The field clinician travels, assesses, treats, educates, communicates changes, and documents the visit while clinical management monitors orders, missed visits, and hospitalizations in real time. At every stage, referral value can disappear, so the owner must measure safe starts, completed visits, accepted claims, collected cash, and unused clinical capacity. Original Medicare does not pay one universal price for every home visit. It organizes qualifying home health care into payment periods with multiple adjustment rules. Each 30-day period begins with a standardized amount, then changes according to clinical characteristics, functional status, admission source, timing, geography, and other payment factors. Under the patient-driven groupings model, each period enters one of 432 case mix groups, so identical visit counts can produce different allowed payment amounts. A qualifying period with sufficient delivered visits may receive the case mix adjusted period payment, linking reimbursement to the classified patient period rather than individual appointments. When completed visits fall below the applicable threshold, the period may become a low utilization payment adjustment and pay separately for each qualifying visit. Transfers and certain discharge or readmission events can shorten the period, producing partial period payment rather than the amount expected for a complete 30-day cycle. Unusually costly periods may qualify for outlier payment, but additional reimbursement depends on defined payment rules rather than simply documenting that care felt expensive. Consolidated billing places many covered services and supplies inside the agency's payment responsibility, preventing every additional clinical input from becoming a separate revenue line. The payment system therefore breaks the simple assumption that more visits always create more revenue. Visit count, classification, thresholds, and resource use interact. Some visits are clinically necessary and protect outcomes, yet higher visit intensity can reduce contribution when payment does not rise equally with delivered resources. A low utilization period may generate less revenue, but the agency must never add unnecessary visits merely to cross a payment threshold. Clinical need remains primary. Then payer mix changes the operating rules, because original Medicare, Medicare Advantage, Medicaid, commercial plans, and other programs authorize, review, and pay differently. Medicare Advantage may require network participation, prior authorization, plan-specific documentation, and utilization review, while rates, denials, claim workflows, and payment timing vary by plan. Medicaid and community-based programs vary by state, while commercial insurance, workers' compensation, veterans programs, accountable care arrangements, and private pay add further revenue paths. The owner must measure authorization, rate, documentation burden, denial behavior, and collection timing, because scheduled care becomes economic revenue only when the claim is collected. Every home health visit is a small production event built around licensed labor, even when the visible setting is simply a patient's living room. Nurses, therapists, and aides are visible, but administrators, clinical managers, intake, scheduling, coding, billing, quality, compliance, recruiting, and human resources support every visit. National wage data provide context. In 2024, the combined aide occupation had median pay near $34,900, while registered nurses were near $93,600. Those national medians are not local hiring quotes because labor supply, competition, travel, benefits, and clinical complexity can move actual recruiting costs substantially. The hourly wage is only the beginning, since a clinician may spend paid time driving, documenting, calling practitioners, coordinating families, training, or waiting. Mileage, payroll taxes, benefits, workers' compensation, overtime, recruiting, credentialing, and supervision raise loaded labor costs before the agency earns any owner-level return. That is why productive visits per paid clinician hour matters more than wage alone when the owner evaluates staffing efficiency and contribution. Two nurses can earn the same pay while producing different economics because route density, cancellations, documentation quality, and schedule gaps change usable capacity. A compact route preserves paid time for patient care, while a scattered route converts the same wage into traffic, mileage, waiting, and late notes. Contract clinicians can add flexibility during growth or shortages, but higher per visit cost, weaker continuity, and scheduling complexity may offset that flexibility. Turnover costs extend beyond replacement wages through recruiting, interviews, credentialing, background checks, orientation, training, reduced productivity, supervision, and temporary coverage needs today. A departing clinician may also carry patient knowledge and referral trust, removing operational capability that cannot be recreated instantly through software or hiring. Demand for care can rise faster than labor supply, increasing competition for nurses, therapists, and aides even when payer rates do not keep pace. The agency cannot safely grow census faster than it can recruit, retain, schedule, supervise, and document qualified care across the service territory. Labor is the platform. Without qualified field capacity, there is no safe start, completed visit, defensible record, accepted claim, or collectible revenue. Now the agency has patients, clinicians, completed visits, and recognized revenue. The next ownership mistake is assuming that the owner already has money. Reported revenue records economic activity, while collected cash marks a treasury event. A claim can appear as revenue before the payer funds the bank account. Start with gross revenue, then subtract clinician wages, contractor payments, payroll taxes, benefits, mileage, travel time, supplies, and other direct episode costs. What remains after direct care costs is contribution, not profit, because it must still support the operating functions surrounding every patient period. Clinical supervision, intake, scheduling, coding, billing, quality review, recruiting, credentialing, and utilization management create semi-variable costs that rise in steps with growth. Administration, office and branch overhead, software, compliance, legal, audit, accreditation, insurance, cybersecurity, accounting, and human resources together form the fixed operating layer. After those costs, the result may resemble operating profit or EBITDA, but the bridge to distributable owner cash is still far from complete. Interest and principal continue below operating profit, so an agency can report acceptable EBITDA while debt service consumes most of the remaining cash. Technology replacement, mobile devices, equipment, security upgrades, and systems investment also require cash simply to preserve the agency's operating capability over time. Growth may absorb working capital, while claims exposure requires reserves, taxes require payment, and the owner's full-time labor deserves a market salary. MedPAC reported a 21.2% 2024 fee-for-service Medicare margin for freestanding agencies, while the reported all-payer margin averaged only 5.0% overall. Those provider-level margins describe reported populations, not a promise that any buyer will receive a 21% cash return after price, debt, and labor. For 2026, finalized policies were estimated to reduce aggregate Medicare home health payments 1.3% from 2025, illustrating reimbursement pressure inside growing demand. In the illustrative base model, $7.38 million of annual revenue narrows to about $248,400 of estimated owner cash after the complete financial bridge. Owner cash is what remains after labor, overhead, debt, taxes, reinvestment, working capital, reserves, and fair owner compensation. Otherwise, profit may be a finance job. Home health moves the service to the patient, so geography becomes part of the cost structure rather than a neutral backdrop around clinical care. Two agencies can share census, payer mix, wages, and visit volume while producing very different economics because one serves compact neighborhoods and the other distant counties. The reported visit count may match, yet productive labor time differs when short routes preserve patient-facing hours and long routes consume them through travel. Territory density changes mileage, paid travel, overtime, schedule gaps, staff satisfaction, and the number of completed visits each clinician can deliver during one workday. Recruiting changes too. A nurse may accept a predictable compact route and reject a role requiring uncertain driving across a broad service region. A branch can move clinical leadership, scheduling, and referral response closer to patients, reducing distance between local operations and the market being served. But a branch can also duplicate rent, administration, supervision, technology, and compliance before patient density creates enough contribution to support those added costs. A distant patient may be clinically appropriate and fully covered, yet accepting the referral without nearby staff can create a route the agency cannot execute efficiently. The agency may use contract labor, delay the start, or stretch an existing clinician, making attractive revenue shrink after travel and schedule disruption are included. Route productivity also changes during the day as traffic, weather, construction, parking, and patient availability alter the time required to complete each visit. Scheduling software can improve visibility, sequencing, and communication, but it cannot erase miles, shorten roads, or create a clinician near every patient home. That creates a useful ownership metric, contribution by service territory, because patient-level revenue alone can hide the geographic cost of producing and collecting it. One county may generate strong referrals, but weak owner cash from fragmented routes, while another produces fewer referrals with denser schedules and better retention. Long routes can increase lateness, missed visits, rushed documentation, and burnout, turning a scheduling problem into a clinical, quality, and financial problem simultaneously. The owner controls territory design more than national reimbursement, making density a powerful lever. The scarce unit is a productive clinician hour inside a workable route. In home health, documentation does more than describe care. It connects the clinical work to the agency's legal and contractual right to bill. A defensible record links eligibility, assessment, skilled need, practitioner orders, the plan of care, completed visits, patient progress, and reported outcomes across the episode. When one link is weak, billing may slow, a claim may be denied, or money already collected may become subject to recoupment. Growth can magnify that risk because more patients create more visits, more records, more coding decisions, and more claims for the same control system. If training, supervision, and quality review fail to scale with census, documentation can weaken precisely when the owner expects operating leverage to improve. Home health quality reporting program noncompliance can reduce the annual market basket update by 2 percentage points, turning reporting discipline into payment protection. Under expanded home health value-based purchasing, applicable Medicare fee-for-service payment adjustments can range from -5% to +5% for participating agencies. Quality therefore becomes a financial mechanism. Outcomes, reporting accuracy, and operational reliability can change payment before the owner reaches distributable cash from each period. Strong outcomes also protect referral relationships because hospitals and physicians value dependable starts, responsive communication, visible performance, and fewer avoidable complications after discharge. Poor quality can attack both sides of the model, weakening current reimbursement while reducing the future referral volume needed to cover fixed overhead. Survey deficiencies create their own costs through corrective action, management time, retraining, policy revisions, record review, and sometimes outside compliance support during recovery. Cybersecurity and privacy belong inside the same risk system because records move across mobile devices, home networks, offices, payer portals, and vendors. A security incident can interrupt documentation and billing, delay collections, consume management attention, and create legal, operational, and reputational exposure across the agency. The legitimate margin strategy is accuracy, accurate assessment, supported coding, complete documentation, and early quality review reduce avoidable denials and protect correct payment. Unnecessary visits, unsupported coding, withheld required care, or retrospective storytelling are not margin strategies. A paid claim can still become tomorrow's liability. After costs, compliance, and collection risk become visible, the agency's legitimate hidden margin appears in repeated operating improvements rather than one spectacular financial trick. Territory density is the first lever. Tighter routes reduce paid travel, mileage, schedule gaps, and clinician frustration across the same service day. That density creates more productive patient care from existing labor capacity without shortening necessary visits, weakening documentation, or asking clinicians to rush through care. Referral acceptance discipline is another margin source because each accepted case should fit the agency's clinical capability, staffing availability, payer rules, and service geography. Fast intake still matters, but accepting every referral can destroy value when the agency cannot begin care safely, promptly, and economically within available capacity. Better start of care execution improves referral conversion and strengthens source relationships by moving qualified patients from complete referral packets into safely staffed initial assessments faster. The improvement comes from stronger intake, staffing visibility, document collection, and coordination, not from skipping practitioner requirements, coverage checks, assessment duties, or clinical safeguards. Scheduling creates margin by matching discipline, geography, patient availability, clinical urgency, and supervisory capacity, so more paid hours become completed, defensible visits. Even small reductions in route gaps, cancellations, and idle time can compound across hundreds of payment periods and materially widen contribution over a year. Accurate documentation and coding protect the payment the agency legitimately earned, reduce avoidable denials, and strengthen the evidence needed during payer review or audit. Unsupported coding is not hidden margin. It is a delayed liability that may return as denials, refunds, recoupments, corrective work, and damaged credibility. Low utilization periods require operational discipline, solve missed visits, staffing gaps, and poor coordination, but never manufacture unnecessary care merely to cross a payment threshold. Payer contracts should be judged beyond headline rates because difficult authorization, frequent denials, administrative burden, and slow payment can turn a higher rate into weaker cash. A lower stated rate with predictable rules, fewer denials, and faster collection may create better owner economics than a contract that looks richer on paper. Centralized support and quality improvement can spread fixed costs, reduce hospitalizations, strengthen referrals, and combine many small gains into the hidden margin across the complete platform. The most dangerous acquisition may not be the visibly weak agency, but the high-performing agency whose recent results cannot survive a change in ownership. The buyer sees rising census, strong Medicare revenue, and attractive EBITDA, pays for continuation, adds debt, and then watches the seller leave. Soon, a clinical leader resigns, several nurses follow, and a hospital relationship weakens because slower response times make the agency less dependable. Referrals still arrive, but fewer clinicians can accept them, so overtime and contract labor preserve some capacity at a meaningfully higher cost. Starts of care are delayed, referral conversion falls, and census begins declining, even though the market may still contain substantial patient demand. Fixed costs do not fall equally fast. Administration, software, office, compliance, billing, and debt service still remain while contribution and liquidity contract. Under pressure, management may cut recruiting, training, quality review, or wage growth, improving short-term cash while weakening the operating platform underneath it. Turnover then rises. Documentation becomes inconsistent, denials increase, collections slow, remaining clinicians carry more work, and referral sources notice the growing delays. The failure engine begins when staffing shortages cause delayed or rejected referrals, reducing census and raising fixed operating costs for every remaining patient period. Cash pressure then encourages wage restraint or expensive temporary labor, which increases turnover and weakens continuity, supervision, and the quality of clinical documentation. Denials and quality problems reduce cash and referrals, making the agency harder to staff and pushing the same operating cycle through another damaging turn. Concentration accelerates the loop because one hospital, physician group, health plan, or clinical manager can create efficiency while becoming a single point of failure. Ownership transfer rules can create a legal trap when assumed billing privileges do not convey, forcing new enrollment or certification before operations in cash stabilize. Seller EBITDA may also depend on underpriced owner labor across recruiting, sales, administration, or clinical oversight, requiring costly replacement hires after closing. The owner trap is paying for a temporary operating peak as a permanent asset. Diligence must verify the workforce, referrals, parks payer economics, records, liabilities, and reproducible platform. To stress test the model, consider an explicitly illustrative Medicare-heavy agency. This is a teaching framework, not an industry average, valuation, forecast, or promised result. The primary operating unit is one full equivalent 30-day period, allowing volume, revenue, visit intensity, labor cost, contribution, and owner cash to connect consistently. In the base case, the agency completes 300 periods monthly, earns $2,050 per period, delivers 8.4 visits, and carries $115 loaded cost per visit. After adding $140 of other variable cost per period, the base case produces approximately $944 of contribution from each completed 30-day period. Across 3,600 annual periods, modeled revenue reaches about $7.38 million, and contribution about $3.4 million before $2.2 million of fixed operating cash cost. That leaves roughly $1.2 million as an operating cash proxy, but debt, reinvestment, reserves, working capital, and normalized owner labor still remain. Subtracting those owner-level claims leaves estimated owner cash near $248,400, only about 3.4% of revenue, despite the agency's substantial apparent scale. Using the modeled contribution and fixed owner-level claims, break-even is approximately 3,337 periods annually, or about 278 completed periods each month. The base case therefore operates only about 22 monthly periods above break-even, leaving little room for census loss, wage pressure, denials, or collection delays. In the good scenario, volume reaches 360 monthly periods, revenue improves, visit efficiency strengthens, and loaded visit cost falls, raising owner cash near $1.42 million. In the downside scenario, volume falls to 250 monthly periods, while revenue weakens and labor intensity rises, pushing estimated owner cash near negative $838,000. In the stress scenario, only 200 monthly periods remain, revenue weakens further, and visit cost rises again, driving estimated owner cash near negative $1.78 million. The decline is nonlinear because fixed overhead, debt service, and minimum clinical infrastructure remain, while census, contribution, and collected cash fall much faster. Management can improve routes, scheduling, documentation, payer terms, and staffing efficiency, but operational discipline cannot fully replace missing patients or unavailable clinicians. Responsible ownership tests several pressures together, because a valuable long-term agency can still exhaust short-term cash when liquidity fails to bridge the gap. There is no universal best owner for a home health agency. The strongest fit is the owner whose capabilities match the operating system and risks. A founder clinician can bring credibility, patient focus, local relationships, and deep care knowledge, creating trust that a purely financial buyer may struggle to reproduce. But when one founder approves every decision, owns every referral relationship, and solves every staffing crisis, the agency becomes dependent on a single person. An experienced regional operator can add recruiting infrastructure, centralized scheduling, payer expertise, compliance systems, and management depth that a small independent agency often lacks. The danger is branch sprawl. Expanding across too many territories can weaken route density, local culture, clinical oversight, and the economics of each additional market. A strategic healthcare owner can connect home health with hospitals, physician groups, post-acute services, or population health programs, potentially improving coordination and access to capital. The trade-off is dependence. The agency may become subordinate to another division or overly reliant on one referral ecosystem that can change priorities quickly. A financial sponsor can provide capital, analytics, professional management, and performance discipline, helping the agency measure operations more consistently and invest beyond founder capacity. But leverage and short time horizons can damage a labor-intensive, regulated provider when return pressure encourages underinvestment in wages, quality, technology, or working capital. A passive owner is the weakest fit because this is not a low-touch royalty stream. Clinical governance, workforce strategy, payer management, compliance, and liquidity require attention. The best fit owner combines strong clinical leadership, recruiting and scheduling systems, payer and denial expertise, working capital discipline, conservative leverage, and scalable technology and quality controls. High control levers include territory design, referral acceptance, scheduling, documentation discipline, overhead, capital structure, and concentration limits. Areas where ownership decisions directly shape resilience. Clinician retention, payer contracts, hospital relationships, case mix, authorizations, and start of care conversion offer partial control, while policy, labor supply, and public health shocks do not. A strong owner does not pretend to control federal policy or local labor supply. The owner builds liquidity, diversification, and operational slack against those forces. From the patient's home, care feels human and immediate. On the owner's balance sheet, it is a regulated platform. That is the economics of owning a home healthcare agency.